Welcome to Verb Voice, interviews with leaders in the clinical research ecosystem. I'm your host, Rob Howie. My guest is Moe Alsumidaie, head of research for CliniBiz, expert in the application of business analytics in clinical research, and editorial advisory board member for Applied Clinical Trials. Moe, good to see you again.
Great to see you, Rob. Thanks for having me on.
You've conducted several studies in the past few years and recently on the correlation of CRA experience with performance. What did you learn?
So we analyzed some data regarding from this group called CRA assessments. And in this analysis, we evaluated CRA performance with experience. When we took a look at that, we evaluated their experience across 8 different domains, and by administering a standardized test to CRAs. What we found, which was quite surprising, is that the data showed that the performance indicators and the scores for each of these CRA levels was pretty similar across the board. So what that meant is that CRA experience did not have any association with the performance on this standardized exam. Now, what does that mean from an industry standpoint is, when we look at the regulations saying that people need to have relevant experience through education and training, we see that, it's possible that someone with medical expertise who understands specific expertise, or even, people who have had experience in medical fields, such as PAs, nurses, and the like, may perform better or similar to a CRA who's had 10 years of experience doing this job.
So it surprised you because you thought there'd be a stronger correlation than there obviously is.
What's a surprise to me is that, when we look at this industry or any industry in general, people are promoted based on their experience, right? Not based on their performance, it seems. And in this case, experience had no effect on performance at all. Like a CRA who has had 1 year of experience, or rather 2 years of experience, performed the same as a CRA who's had 10 years of experience.
The shortage of CRAs is a challenge that has been with the industry for a while, and it appears to be getting worse. Why do you think that is, and what will it take to solve it?
The shortage has been around for a while. I mean, if you look at it, what the NACRP report that was released several years ago, specifying the specific issue of the CRA shortage, this shortage has been amplified by post-pandemic, where CRAs have moved jobs and they're looking for either higher paying or jobs with more responsibilities at other companies. When I took a closer look into this, we've seen a ton of job openings for entry-level CRAs compared to the senior level CRAs, which is natural in any case. Nonetheless, I mean, we're looking at like thousands of job posts per month. So the challenge here, from what I'm hearing, is that the industry sort of has this expectation that CRAs have to have 2 years of CRA experience, or rather clinical research experience in the industry, or not necessarily in the industry, or even in a research institution perspective. So, to the few fortunate research coordinators who can make it into those entry-level positions, they get in there, but the sites eventually are impacted with high CRC turnover rates. So there's a glut of CRAs in the market. Those who have some experience move on to higher or different positions, or they burn out, versus, there aren't enough of a pool of people to hire into those positions. And what's even more interesting is, as protocols grow in complexity, demand for CRAs is also increasing because of the amount of work and effort it takes to monitor those studies and manage those studies. So you have more visit procedures, you have more complexity, the sites need more attention, the sites are using many more technologies requiring the help of CRAs, and there's just not enough resources. So to get over this, I think that we need to pay attention to what the regulations say specifically around the requirements to have a CRA in the role, which does not specify how many years of experience and what exactly, which type of experience they have. They need to have appropriate medical training or experience and training in clinical research. So I think that if we open that up to follow what the regulations do say, we'll be able to address the glut through a combination of accepting people who have less than 2 years of clinical research experience, but are qualified to work on protocols, and to have really robust training programs and oversight after those people have been hired to get to a point where they pass performance expectations.
You mentioned training, Mo. That's obviously one key to preparing recent college graduates and laterals from adjacent spaces for a clinical research career. But much of the training out there doesn't seem up to the task. What kind of training is needed to actually prepare people to monitor clinical trials?
Well, what's interesting is that when we took a look at the training, after vertical integration no longer became a priority for sponsors, meaning they started to outsource more of their studies to CROs, they kind of ditched their internal training programs. And what I meant by internal training programs are not read your SOPs and then follow up with, expecting people to do the job. No, we're talking about those classes that people used to attend at the sponsor level that trained CRAs to become CRAs. Robust, and that's what I mean by robust training, is putting people through an experiential learning on dealing with becoming a CRA, understanding how to do source data verification, learning how to read the medical records correctly, and deciphering their knowledge from a combination of their expertise along with the training to achieve quality outcomes. So what I mean by that is we need to have both a conceptual or a learning training part through classes, of course, and then an experiential portion that helps to train people on the job as well. I think also support tools when people, CRAs are in the field. So for example, we're just recently at the Tufts conference, the CRA roundtable, I was discussing the potential for AI chatbots, like, for example, I've got a question about, if there's a particular finding, for example, fraud, or if there is a potential adverse event, what do you do per the company's SOPs? Those things can be really helpful on the ground, especially in the beginning where, when right now there are resource strains that are happening, whereas people may not be available to pick up the phone immediately. So it's a combination of training, experiential training on the job, and tools for information.
And I'm sure you'd agree that in the training, it's not just the hard skills, but the soft skills of speaking truth to power, of having the confidence of being able to talk to a principal investigator, and the communication skills, and as I said, the confidence to actually influence the site.
And most importantly, the medical knowledge to understand the protocol. Has the patient, for example, been dosed correctly, or was there a dosing issue, right? So to see behind what presents to you on, in face, and that also, interacting with the PIs and keeping the sites motivated are also things that are a big challenge nowadays, because of the lack of CRAs being there on site. They're just overwhelmed. And so, when all the CRAs are doing is SDV most of the time, it's a challenge to engage the PIs and keep the sites motivated. So there's also that soft skill where you need to understand how to engage the PI and keep your study a priority amongst other competing trials at the site.
You mentioned the Tufts Center for the Study of Drug Development recent event, which looked at the correlation of CRA experience and performance. You spoke at the event. What conclusions did you draw from what you heard there?
It's interesting. In the beginning of the event, many folks were talking about how challenging it is and how challenging it was to address the needs of the sponsor and also the CRO expectations too for having those 2 years of experience. And a lot of the issues that were discussed were around the misconceptions that, we needed to have these 2 years of experience. I mean, listen, it makes sense that people couldn't really point to where it came from, but really it was one of those regulatory initiatives years and years and years ago that focused on CRA experience. When, and then the industry sort of followed and it became sort of the norm in the industry. And also the combination of ditching training programs and just saying, oh, well, we just hire CRAs with experience and we don't need to invest in training programs anymore, right? And so that's kind of where the concept came from. And it seems to me that a lot of people were hyper-focused on that and we're discussing the challenges surrounding that, like availability of CRA, like the cascading issues that are a result of that, like, for example, the quality of and the performance of your CRAs, the availability of your CRAs, whether or not they have the sufficient skills, and oversight challenges, like how do you measure CRA performance? Those were all things that showed up, right? And the reality is this, like, if you're only going to get in trouble if you have compliance related issues specific that are person related. For example, if your CRA is not performing up to par and it has been identified that that is the case, like through an audit, for example, and the sponsor knows about it and did not do anything about it, that's when regulators will take a look into the experience and really look at the people aspect of what's going on. But other than that, if people are doing their jobs and there aren't any findings that are related to people specifically, but rather other areas, like, for example, the site might have the issue, or it's a technology related problem where there was an oversight due to an integration issue, or the PI may not, has missed an adverse event reporting. Those are all things that are very common that happen at the site, are usually picked up by staff personnel. But really, it's all about remediation and CAPAs, or corrective action plans. So it really has to do, I think, more with the process of executing your studies than it does with the people, rather. Because most of the times, as I was mentioning earlier, the performance doesn't seem to be related to the experience aspect. It's more a process, a quality management process that needs to be addressed. If there is the fear around, did I hire someone who's not capable of doing the job?
Well said. Our guest is Moe Alsumidaie, Head of Research for CliniBiz. Moe, as always, thank you for joining us today.
It's my pleasure, Rob. Thank you.